Hi, everyone. This is Lynn Crawford from Hope Dementia Support, and I am so pleased to welcome Dr. Angela Hanson, who will be talking to us about medications used and not used in dementia. So about Dr. Hanson, she's board certified at the Memory and Brain Wellness Center at Harborview, and she is a University of Washington active assistant professor of medicine and gerontology and geriatric medicine. She's interested in improving the healthcare of older adults, particularly those with dementia. She believes the best healthcare plans are both evidence-based and patient-centered. She earned her MD at the University of Colorado. She is board certified in both internal medicine and geriatric medicine. Her research interests include understanding how dietary factors can affect cognition and Alzheimer's disease progression. In her free time, Dr. Hanson enjoys trail running, hiking, reading, and playing the piano. So welcome, Dr. Hanson.
Thank you so much for having me. Let's hope that all of those things continue. I am currently studying for the 10-year boards right now. All right, did I raise my own hand? What did I do? All right, let's see if I can share my screen here. All right, and hopefully my volume is still good. We did a test earlier, but I will be talking to you today about medications. Maybe medications you could use, or maybe medications not to use when your loved one or if you have dementia. I try to cover a broad range of topics today, but I'm hopefully going to give a lot of time for questions. Of course, this is as a typical disclaimer. I just want to make it really clear. These slides should not be used for medical advice. Please consult with your medical providers before stopping or changing any of your medication. But hopefully this is a lot of general advice that will inform you about what's up. Okay, so as a geriatrician, so that's a doctor that cares for older adults, I do a lot of teaching. I teach the next generation of geriatric fellows, and I made this slide to teach them about this topic. When a person has memory loss or any kind of cognitive impairment, there are a lot of factors that can go into this. So these overlapping circles are what you see here. We call cognitive impairment a geriatric syndrome, which means it's complicated. Something like visual impairment or falls. A lot of things can contribute. It's not usually one thing that can happen to make the symptom happen. So here, over here, we have, of course, neurologic diseases like dementia, Alzheimer's dementia, or stroke dementia can cause cognitive impairment. But so can medical diseases. If your diabetes gets out of whack, or your thyroid needs adjusted, or if you have really uncontrolled sleep apnea, that can make it hard for you to think the next day. Also psychosocial, if your caregiver is in the hospital and you're out of sorts because your social support, or because COVID happens and all your social supports just kind of got upended. Psychiatric conditions like depression or poor sleep can interfere with our ability to think clearly. And lastly, medications, either lack of medications if you're not taking your meds properly, or some medications can actually cause cognitive impairment. So all of these different topics, all of these different factors can lead someone to have trouble with memory or thinking. So it's our job in memory clinic to put the puzzle together if someone comes to us. Yes, we diagnose things like Alzheimer's, but we also try to optimize all these other things to make someone have their best life. All right, now everybody gets to have a quick neurology lesson. So I want everybody to imagine they're in a big conference room with a chalkboard. They're a student, they're a medical student or a nursing student. And you're about to learn about neurons. So we're going to talk about neurotransmitters on the next slide. And the reason why is I need to explain a neurotransmitter called choline, or the longer name of choline is acetylcholine. Choline is one of the neurotransmitters that our nerve cells use. Another neurotransmitter you may have heard of is dopamine. These are used by both the brain and the nerves in your lower body, like your bladder and your muscles. This is important because if you start taking drugs that affect choline, you might affect your bladder and your brain at the same time. That's sometimes where side effects come from. Okay, this is a very simple drawing of two nerve cells. So here we have one nerve cell called the presynaptic neuron, and then this is the postsynaptic neuron. Hopefully everyone can see my little pointer. So the presynaptic neuron, the way neurons talk to each other is really fascinating. The first thing that happens is this neuron, this top neuron got a signal from another neuron that you can't see. And the signal transmits electrically, like in your electrical cords, okay? And then when it gets to the edge of the neuron here, it releases these chemicals in these packets. And this chemical actually releases in space as if it's passing a note. And this chemical has to reach the postsynaptic cleft here and bind to the postsynaptic neuron. And then once that binds, now this second neuron sends its electrical signal. So it's an electrochemical synapse process. And the fact that this happens trillions of times a second in our brain is just mind-boggling to me, really. But this is what we're talking about when we're talking about neurotransmitters. And the way that we can interfere with them is when they're down here. It's the easiest way anyway. So choline or acetylcholine is this pink circle with the hat, okay? And when it's released, it binds and then it has a signal. Well, obviously you don't want this signal to go on forever and ever. So there's this chemical called acetylcholinesterase. What a mouthful, and I'm so sorry. But it's like a little Pac-Man that chews this up into its components, and those get reabsorbed. So the signal can stop. It signals once and then it's done. Okay. So this is kind of the base system of how choline works. And the reason I'm focusing on choline or acetylcholine is these are the synapses or the neurons that we think go awry early in the disease Alzheimer's. They can also go awry in Lewy body dementia as well. So different types of dementias, you have trouble with the choline neurons. So now we have the little thing up here. So ProCholine, if you want to boost the signal, boost choline, what you do is you block this Pac-Man. You say, hey, don't chew up choline so fast, okay? Let it go a little longer. And then you might boost the signal. And that's exactly what happens when you take Donepezil for Alzheimer's. And here's that big long word again, acetylcholinesterase inhibitor. I cheat and call it a choline booster, okay, because it's way easier to say. But these choline boosters inhibit the breakdown of this acetylcholine, and it improves the neurotransmission. And that's how the Donepezil drugs work at this level. There's a whole type of drugs that we're going to talk about that are called anticholinergics. Now, some drugs are anticholinergic on purpose, like Detrol for the bladder. Choline works to help your bladder relax. And if you have an overactive bladder, you can take Detrol, and that helps your bladder not contract and helps an overactive bladder. So some people take anticholinergics on purpose for bladder spasms, but unfortunately that also, if it gets into the brain, some of the earlier bladder agents actually also get into the brain. And an unfortunate side effect of bladder medications is that it also blocks this. There's also drugs that they have side effects that are anticholinergic, and that would include Benadryl. The main reason you take Benadryl is its effect on histamine, but it unfortunately is a messy drug, and it also blocks choline. It blocks, it looks like this, and it looks like choline, but it doesn't make the signal go. So it actually blocks this whole process. It's a competitive inhibitor of acetylcholine. So you can see, I'm going to go back. This is a ProCholine drug that makes the signal work better. This is an anticholinergic, which blocks the signal. So ProCholine and anticholinergic drugs are like enemies, and they don't work well together. And we're going to talk more about what that means. But I just like to show that visually to people when we're talking about choline. So anticholinergics. Anticholinergics, these drugs, and I'm going to talk a little bit more about what those drugs are. There's multiple studies now that show if you're taking these drugs for a long, long time, it may be that they can cause cognitive impairment all by themselves. And they may actually, I'm going to go back, if you keep blocking the synapse, this synapse might actually go away. And it could potentially be that they can cause Alzheimer's. At least they increase the risk a little bit. So the recommendation is now to reduce or stop as many anticholinergic meds as you can, or try to find alternatives. So what are these drugs? These are the main common ones. So anti-bladder medications like oxybutynin or ditropan, that's a common one. There's the scopolamine patch is an anti-nausea medicine that blocks, that is an anticholinergic. Old school antidepressants that have the lean in it, amitriptyline, desipramine, paroxetine. Now, a lot of antidepressants are what's called SSRIs, which stands for serotonin reuptake inhibitors. And those are not anticholinergic, except for this one example that might be. Allergy meds, Benadryl. If you take a Benadryl occasionally with seasonal allergies, it probably doesn't do anything. But if you're taking it every day for years and years, it may be that it will block that system. And there are better medications now that are not anticholinergic. The best way to know if you're on a medication that's anticholinergic, of course, is to talk with your doctor or pharmacist about your medications and say, hey, am I on any medications that are anticholinergic or that block choline? And they can help you look through your list. Other medications just to be aware of course, any medication that's sedating can make you have a hard time thinking straight. That's true for anyone, young, old. Benzodiazepines, which are like Valium type medications, lorazepam, clonazepam, Ativan. These can increase confusion and risk of falls. Opioids and gabapentin, they do play a role in pain, but they do increase the risk of being sedated. There's a lot of medications that can have sedating effects or have cognitive side effects. So again, it's important to know what meds you're on and talk with your doctor. If you get put on a medicine and you think it's making you feel loopy, definitely let your doctor know. All right, now I'm going to focus on the FDA approved meds, the FDA oral approved medications for dementia. Okay, so I'm just going to talk a little bit about some general facts. So there are 4, 5, or 6, depending on if you're counting the combo pills and stuff. There's basically 4 types of medications, 4 individual chemicals anyway, that are approved for dementia. We're talking oral pills. 3 are the ProCholine boosters, and 1's kind of an oddball, and we'll talk about it as well. Here's some general facts about the meds that you might be prescribed for dementia that are FDA approved for Alzheimer's disease. These drugs are fairly safe. And they don't have very many drug-drug interactions. They're not likely to interfere with your heart medications or diabetes medications, that kind of thing. They all have been shown to be effective in clinical trials. They do show improvements on mood and memory tests in clinical settings, but they don't cure the disease. They help boost those signal of the neurons that are left, but they don't cure the, they don't cure the underlying disease process, unfortunately. And what I wrote here is results in the real world will vary. So I see a lot of patients with dementia, and I do see some patients improve quite a bit on these medications. And then some people seem to be like, I don't know, I'm not sure if this is helping. I'm going to kind of go to the next slide. What I wrote here is decisions about these drugs can be tough for families in the sense that sometimes I think it's just hard to know if they're working, or are they stabilizing, or question mark. You know, it's not like your blood pressure pill where you know for sure the number went from 160 over 90 to 140 over 80. You know it's working. The medicines for dementia, you know, they work slower, and they don't cure the disease. So it's just sometimes hard to know. So what I would say is when I prescribe these medications, the first thing that I want to make sure that is happening is that the drug is not harming somebody. First, do no harm. Is the patient having any really bad side effects, or is it too expensive? And then after that, we have discussions about, do we think it's helping or not? And we carefully have that conversation. And then I'll talk a little bit later about when we decide, is it time to stop the medicine? But I just like to, you know, point out this to families is that these decisions are tough, and I don't think there's a right answer. If you want to try these medications, it's okay. If you decide not to try these medications, you're not missing out on a cure, and that's also okay. These decisions really have to be individual to you and your family. All right, so what are the drugs? You may have heard of them. So the Choline Boosters, there's 3. There's Donepezil, also known as Aricept. It's a pill. There's galantamine, also known as Razidine. It's a pill. And there's rivastigmine or Exelon. It's a pill and also comes as a patch. So for people who can't take pills or prefer patches, they're all pretty similar. You know, if you really want to get into the nitty gritty, there's slight differences in side effect profiles, but they basically all act the same. If a person does well on one medicine but might have side effects, sometimes we'll try a different one to see if they do better. And then some have once a day dosing and stuff like that. So, you know, if these are helping, but the dosing is weird, you know, talk with your doctor, maybe a different formulation can help. So those are the choline boosters. There's also Memantine, aka Namenda, and it acts in a very different way than choline boosters. It's an NMDA receptor antagonist, and I'm going to talk a little bit more about that in a second. Finally, there's some combo pills. So if you end up getting stable on all these medicines and, you know, pill burden is an issue, there is a combo pill. I have to say sometimes the combo pills are expensive. But if you can afford it or your insurance does cover it and you know you're not going to be changing the dose, combo pills can be helpful. Okay, so a little bit more about the choline boosters. I showed you the info about how they work. We talked about the 3 kinds. Donepezil or Aricept's the one a lot of people are familiar with. Who are they for? They're FDA approved for mild, moderate, and severe Alzheimer's. They're also used for Lewy body dementia, especially for those that have hallucinations. They may be used in other dementias as well, like vascular dementia. There's a lot of overlap between vascular or stroke dementia and Alzheimer's, so it seems reasonable to try the medication in both. It's not useful for frontotemporal dementia. What does it do? This is from an Alzheimer's source. Donepezil delays the progressive worsening of cognitive symptoms. It's pretty clear, study after study shows that these do improve the memory scores and different cognitive scores. But like I said before, what that means out in the real world is different for different people. You know, if you have someone that used to drive and be really independent and then they can't drive anymore and they're so frustrated and angry about that, but they can remember a few more words and do a few more things, but they still can't drive and they're very angry about it, you know, the Donepezil may not help that anger, right? Because they're angry about not being able to drive. So I think it's just important to keep in mind that clinical significance in the lab, when we show error bars and yes, they improved on this cog test. I am so sorry. I have to tell my light that I'm still here. I'm still here, office. Thank you. My office is being very helpful to the environment, but I'm still here. So what I'm saying is, we do know that these medications do help on testing, but out in the real world, you know, sometimes it's hard to see a difference clinically. And I think it kind of depends on how someone's life is set up. So I think you'll hear me say that over and over. It's like there's the clinical and there's the real world experience. What are some of the side effects? You want to be careful with this medication if you've had what's called a GI bleed or any kind of low heart rate problems or problems falling. So like I said before, choline is used in the lower half of your body as well. Your heart uses choline as a signal, your bladder uses it, your GI tract uses it. So that's where side effects come from, is that your body actually uses that choline in other spots. And then these are some of the other side effects. So nausea, GI side effects are the most common. So diarrhea, nausea, and vomiting. Pretty common, especially when you first start it and you go up on the dose. So that's why we start low and then we go up after 4 weeks. A lot of people get a little nausea and diarrhea and then it goes away. Some people it doesn't. You really don't know until you try it. If you're already on a medication that is a heart rate blocker like metoprolol, you want to be cautious when using this medication. These are some other rare side effects. Vivid dreams. Vivid dreams isn't a problem by itself, but if someone's having a lot of nightmares, dizziness, headache, rare urinary incontinence, but certainly something to watch for. And again, a lot of side effects appear at the beginning and then go away as your body adapts. All right, Memantine, I said, was kind of the oddball one. It acts, we're not really sure how it acts. There's a couple of hypotheses. We know that it blocks this thing called the NMDA receptor. And we think what that does is it lessens this excitotoxic glutamate. So glutamate's another neurotransmitter. If you have a lot of glutamate around, it's kind of toxic to synapses. And so if you kind of clamp that down, maybe that helps. But honestly, I don't think we really know for sure. Who it's for is for moderate to severe Alzheimer's. It's not been shown to help people with mild cognitive impairment or mild Alzheimer's. The exception to that is if you have mild Alzheimer's disease and you cannot take Donepezil, you can start taking Memantine instead. Now, what if you're on these meds already? You know, the textbook says that people with mild cognitive impairment don't benefit from Donepezil or they don't benefit from Namenda, but you're taking it and you actually feel a little better. Well, you know, if I see a patient in my clinic and they're already taking these medicines and they think that they're helping, I leave them on it. You know, I think it's just worth having that conversation. We either leave them on it or we can stop it and resume later. You know, I just counsel them, well, it technically hasn't been shown to help people, but maybe you are benefiting. What is Memantine supposed to do for you? One study said that it improved delusions, hallucinations, agitation, aggression, and irritability. Another study showed that it modestly improved attention, global well-being, daily function, and independence. So maybe a little bit less in the cognitive side, but a little bit more with the behavior side. And that is probably why it's been shown to help the more moderate stages rather than the early stages. Okay, this causes me anxiety right here. The dosing schedule is really complicated. You have to do 5 milligrams for 1 week, then 5 milligrams twice a day for 1 week, then 10 milligrams and 5 milligrams, and then 10. Are you confused yet? So am I. Okay. So I kind of wrote it confusing on purpose a little bit here, but just be really aware of this or any medication. If the doctor starts writing complicated medication, things like this, just that, to make sure that a pill box gets purchased or that somebody's really monitoring. And to complicate things even further, this is what I see happen with Memantine, is I'll write 2 prescriptions, one for the Memantine uptaper, which is usually in 5 milligram tablets. And then the renewal will be in 10 milligrams. So the caregiver might think that the renewal is the 5s and fill the two pills instead of 1. And then they're overdosing on it. So this, like I said, this medicine causes me anxiety because of the way it works and the way insurance companies like to fill it. So when I write it, I kind of write everywhere, please be careful and read the instructions really carefully. And I call the pharmacy and I still worry about it. The side effects of Memantine include nausea and vomiting, diarrhea or constipation, but not as common as Donepezil. Dizziness is kind of common. I've had a couple of patients not tolerate the full dose. So we go down to like a half dose and they tolerate that. There's some other scary side effects that are listed on Micromedics. That's the Micromedics is what I use. It's kind of my Bible for drug side effects. Unfortunately, you have to have like a login or, it's not available to like the general public. But your doctor should all have access to it. But when you look at the scary side effects, stroke was listed higher in the placebo group. So I don't know. It's technically listed as a side effect, but I don't know if I believe that really is a true side effect. You do have to go down on the dose if somebody has kidney problems. I would say, and I don't know if I mentioned this before, none of the FDA approved medications, oral medications for Alzheimer's have a black box warning. So a black box warning is when a drug has kind of a scary side effect that the FDA wants to make extra sure you pay attention to. And these drugs don't have that. So that's good. Okay. This wouldn't be a drug Alzheimer's talk without mentioning this drug. So aducanumab or Aduhelm got a lot of press, a lot in the news. It's still in the news. This is just the very brief update on it. It was approved in June for Alzheimer's. Stay tuned. It's going to take months to roll out. It's an IV infusion once a month that helps get rid of amyloid plaques. There's a lot of caveats and nuances to this medication, a lot of contraindications. A lot of people won't be eligible, like if they're on certain kinds of blood thinners and things like that. Harborview, that's where I work, is having a meeting soon to discuss whether it will even be on the formulary. Medicare and Medicaid really haven't said anything. We're all kind of like waiting for our marching orders. But we do have a website that has updates, at least if it's available at UW. And the website is there. We can share these slides with everyone at the end if need be. I think this is recorded. So it's a fairly easy website to type in. So please keep checking back for updates. We're going to try to update that. As we know information, we will tell you. So behavioral agitation and dementia, I'm anticipating, more questions about this. I didn't put a lot of slides in here. This is another tough topic. There are no FDA approved medications for just this topic. although there's a lot of what I call off-label use. So we will sometimes use short-time medicines like quetiapine or Seroquel or risperidone. So those are antipsychotics. Those are meds that we use for like schizophrenia and things like that, or anti-anxiety medicines like lorazepam. They have significant risks. They have black box warnings. I talked about the black box warnings. You know, the FDA approved medicines for dementia do not have any black box warnings, but these do. Many of these do. And they have significant side effects. The black box warning is for increased risk of death in older adults. It's a small but real increased risk. So we don't want to use them lightly. My practice is if we do use them, we use a low dose for really bad behavior in a situation like someone is moved to a new facility and their behavior is really out of whack, but you know it's going to calm down eventually, but you're using it as a bridge to trying to get resources in place or things like that. So low dose with a set endpoint, that kind of thing. Or if someone's really having a lot of hallucinations or psychosis, these medicines are, make sense to use. But here's what I would say. Make sure that the Alzheimer's drugs have been tried first. A lot of times they haven't really been tried, like Memantine. Memantine, as I said earlier, I'm going to go back, look at those FDA approved for delusions, hallucinations, agitation, aggression. Now, not everyone, it works. And I've certainly had phone calls from nursing homes where they're on max dose of Donepezil and Memantine and they're still throwing their coffee cup. So I don't want to overpromise any of these medications. Dementia is a hard illness. And when you can't remember where you are and you don't think you're in your home and someone's coming at you to try to change your clothes, like imagine how scary that would be. So these medications aren't, a panacea. They're not a cure. But before we try any of these, I make sure that we've tried Memantine and those other medicines because they are safer and they might help. Of course, the best treatment for behavioral agitation is all the non-pharmacologic things. If you can figure out the triggers, modify the environment if possible. And so I put the resources there, Alzheimer's Association, the groups that you're here now, Hope Dementia, of course. There is a 24-hour helpline for Alzheimer's, and Lynn Crawford can pipe in with resources as well, I'm sure. Those are just the ones I throw out there because they apply to everywhere and everywhere. But this is hard. This is a hard one. And if your loved one is on these medications and they are helping, I certainly wouldn't run and wrench them out of their hands. But I just think it's important to know the kind of risks and benefits. And I think it's always a good question, like, hey, is it a good time to try off? They helped now, maybe we can back off on them. Because you certainly don't want someone to fall or have a side effect. I put just a couple slides in here about kind of just general principles about medications. So I use a MediSet. So I just full disclosure for you all, I have a condition that requires a couple of medications and, I don't know, like remembering if I took them or not. I can look in my pill box and see if I took them or not. So it's super helpful. So I'm a strong believer in a MediSet. As we age, some things to know. Medications are metabolized differently. Our kidneys are slower to clear some of the medications. If we're on more drugs, there's a possibility of more drug-drug interactions. So we have to be careful about that. Sedating medications might be more potent. So a higher dose might cause more toxicity. That being said, older adults often do need medication and do well taking a medication regimen that's very thoughtful and helps them live a better life. So don't throw out all your meds just yet. I think it's just something we have to be careful of. So the Institute of Medicine got together in 2015 and they have this really long PDF. If you want to read it, it's like 200 pages long. The top 3 actions you can take to protect your brain health. So how to keep your brain healthy as you age. The top 3 things were reduce your heart risk factors. So keep your heart healthy, be physically active. And number 3 was manage your medications. And what they meant by that was know what drugs you're on, bring in all your pills to your provider and make sure that they know what you're taking, prescribed, over the counter, and herbal medications. Ask your provider whether your medications might be causing cognitive impairment. So these are just a few things that I think might be helpful. So, you know, it might be intimidating to do that, to bust into your doctor's office like, are these drugs making me stupid or whatever? Like, I mean, who wants to do that, right? But here's some suggestions that I think might be helpful is set aside a visit. So when you go to make a doctor's appointment, you almost always have to give a reason. Like, is it pain or follow up or what is it? And put in, I want to talk about my medications, and they'll see that and talk to you about it, or tell the nurse when they're taking you in. And here are things you can ask. Are there medications that I or my loved one should stop or go down on? Do any of these medications interact with each other? Can my medication list be simplified? And what I mean by that is, let's say you're giving your medications to your loved one and they're like, they dose 3 times a day. And that's hard. They fight every time. So wouldn't that be great to only have 1 fight a day instead of 3 fights a day? So what I do in my clinic a lot is to try to simplify medications. And if medications are a battle, you know, say, well, when are they most likely to take their meds? Oh, in the morning. Okay, well, let's give all their meds in the morning. And usually you can do that. Like, there's this idea that statins need to be at night. They don't. Take it in the morning, because if you don't take it at all, it doesn't work. So talk to your doctor about, can you simplify? And then, you know, let your doctor know if your medications are expensive. You know, sometimes we don't know or don't realize, and, you know, the formularies change. Like some medicine that we used to prescribe all the time, all of a sudden got more expensive. And often there are other options. So I'm really appreciative if a patient tells me. I mean, I should be asking, but let your doctor know, hey, this is really expensive. I can't afford that. Here's another really underused resource. Your clinic might have a pharmacist that you could set an appointment with. So Senior Care Clinic and Harborview, we have a pharmacist that you can use, and they like sometimes spend like an hour, and it's so amazing. They go through all the meds and they make a plan. But if you pick up your meds at Rite Aid or whatever, those pharmacists they have about as much training as a doctor does. I mean, use their insight. They can look up all your meds and see if any of them are AntiCholine, right? They can say, oh yeah, I'm going to put a message into your doctor that maybe you should change your Paxil to something else. You know, I'm interested from the group to know, you know, mail order pharmacies make me a little nervous because you can't just go in like, hey, Bob, tell me about my meds. But I'm sure they have pharmacists on the phone that could help you, or even on eChat or something. But I guess I'm kind of old fashioned. I like, you know, that face-to-face contact and, you know, looking at your meds. And then, you know, anytime you're getting a new medication, be really careful when your doctor changes your prescriptions. I'll tell you a really quick story. It's one of the stories that kind of helped shape my geriatrics career. When I was an intern, so a baby doctor learning how to be a doctor at the University of Washington, we had a patient who came in, an older man who had had a stroke about a month before. And his wife said, you know, he's acting loopy. He's sleepwalking almost. And he got an MRI, a CAT scan. He got all this imaging, and his stroke was the same. No new stroke. He wasn't bleeding in his head or anything. So I went in and I took a longer history, and it turns out he had just been to the doctor. His doctor increased his lisinopril and started him on Ambien for sleep. But he got his meds mixed up, and he was taking 2 Ambien in the morning and his lisinopril at night. So he was sleepwalking. His wife diagnosed, and he like got $1 million workup for no reason because his medicines got mixed up. So be really, really careful when your medications are changed. And it could happen to the best of us where you just mix up your medication. And be aware that they can interact. So bring them all in. Don't assume. Supplements like Tums can interfere with absorption of medicines, like something that seems so benign. So just be aware. And again, that pharmacist can help you really quickly. I mean, they probably don't even have to look it up. I have to look it up on the computer every time, but they are so sharp, and they're really detail-oriented folks. They catch our errors all the time. So I'm so grateful for pharmacists. We should use them more. When do we stop medications? Like, this is a really interesting topic in geriatrics, just in general. We take a lot of medications to prevent disease. And, if you live to be 106, does a 106-year-old need to still take their aspirin or something? I mean, maybe, but, it's something we talk about in geriatrics is it okay to stop medications? Do they outlive their usefulness? And at that point, you're just, taking all the side effect burdens on without getting any of the benefit. The benefit already happened when you were in your 90s for the 106-year-old. So here's what I would say. It's okay to have that conversation. It's okay to say, do I still need this medication? Or is this medication still helping me? And the answer might be, yeah, or I don't know, or we could stop it and see how you feel. You can always go back on it. If you stop a medication, like a medicine that's just designed to make you feel better, and you feel worse when you go off of it, you can always restart it. If it's a medication that's supposed to be preventative, there are some guidelines I put in here. So now we know that if you've never had a heart attack or a stroke, you probably don't need an aspirin anymore. Again, consult with your doctor first. There's a lot of caveats, and if diabetes, and there's some caveats, but we're finding out, we do more studies and we get more information. What I do with the Alzheimer's meds, so things like the Donepezil and the Memantine, we have a conversation at every visit, but I stop them or talk about stopping them when there's a lot of side effects, of course, when it's really clear they aren't working, when patients are having trouble swallowing. And what I say is, you know what, I think it's time to take a timeout. Like if a patient has a decline in their function, or having trouble swallowing, or gets moved to a new facility, I say this is a good time to take a timeout. Let's review your medication list and see if there's anything that you really don't need anymore, that's not helping you anymore. And, I think families are appreciative of that, because sometimes it's the first time someone ever said to them, like, it's okay to stop medicines. I mean, the reason you're on medicines is to help. The benefits outweigh the burdens. And at some point, if the burdens are outweighing the benefits, then it's time to stop. And then there's some medicines we might start, like vitamin D to prevent falls, or a medicine to prevent constipation or something. So, there's always a medicine you might add, but but I really like to drill this in that, like, you don't have to take a medication, and you don't have to take that exact medication, and you don't have to take that exact dose. There's always another plan. Okay, this is a picture I took of let's see, what was it called? The Stabler Ledbetter Apothecary Museum in Alexandria, Virginia. When back in the old times, when you used to travel for conferences, this was so fun, going to an old apothecary back in Virginia. They had like a handwritten order from Martha Washington, who wanted to order something for George. It was so fascinating. But yeah, if you ever get a chance someday to go to this apothecary, it's really neat. These were some drawers that had names of old medications that doctors or healthcare workers used to prescribe. One of them is called Dragon's Blood. I cannot get over that. I used to be able to prescribe Dragon's Blood. I don't know what it's for. I just love it. But this is just basically a prompt to talk about supplements. So supplements, this might kind of be obvious, but there's not one food or supplement that's going to cure or prevent a complicated disease. And be aware that most supplement claims, like this is going to cure this or that, most of those claims have not been evaluated by the FDA. Because they're a supplement, they get to kind of say what they want, as long as they kind of say it with asterisks. But the good news is healthy diets have been shown to reduce dementia risk. So the Mediterranean diet and the MIND diet. And so these are 10 foods that we know help prevent brain decline. So the MIND diet is basically a Mediterranean diet that's fortified with healthy foods like chicken, fish and seafood, green leafy vegetables, and other vegetables, berries, nuts, especially like walnuts and pecans, olive oil, wine in moderation, beans, and whole grains. So my advice is the supplements probably have less data. So especially in this area, we have the luxury of farmers markets until October, and we have fresh seafood all the time. Save your money and buy seafood twice a week and get some green leafy vegetables. And those have been shown to prevent cognitive decline in study after study. And those are probably better than supplements. I know that's super boring advice. It's like eat right and exercise. Oh, but it has really good data. And we're so fortunate to live out here where we have the access to all this yummy food. So the summary, there might be some medications that are harmful for brain health. So it's really important to talk to your provider and your specialty providers too about, are you on any of those medications and what are the alternatives? Here's what I'd say is the meds that we use for Alzheimer's that are FDA approved are fairly safe. They do have evidence of benefit, but what that means out in the real world is different for every person, and it's okay to stop them if they don't seem to be helping or if they seem to be causing side effects, or even just trying going on a lower dose. Be mindful of if you get a new medicine or if your dose changes, just make sure that you're following those prescription instructions. Know your meds and set aside a visit to talk with your doctor about your medications. Use your pharmacist. I think they're probably underused for advice. And then stay tuned for news about AntiCholine and other drugs like it. There are other drugs that are being studied in phase 2 and phase 3 that are even oral that might be coming in the next couple of years. So, while I'm a little skeptic about AntiCholine because it has to be given IV and stuff, I'm hopeful that at least these kind of drugs are on the horizon, and hopefully we will have a cure for some of these diseases. Thank you so much for having me. And now let's have some questions.
All right, I'm going to ask them in the order that they came in. How long will Aricept help dementia? My wife has been taking it for 8+ years. And I know you dealt with this a little bit, but.
Yeah, that's a good question. You know, it hasn't really been studied in terms of how, like, when do we stop it? It is clear that it seems like these drugs wear off eventually. And when does Aricept wear off versus when does Memantine wear off? Because they kind of get started at different phases. It may be that within 5 to 10 years they start wearing off. But the honest answer is I don't know if we know, because no one's really done those studies. And it's hard to study because nobody really wants to kind of do it, right? What I would say is if you have a loved one that's on Aricept and, you know, you are pretty sure it's causing no harm. So they're not losing weight. So weight loss is a really important vital sign for your doctor to check. So they're not losing weight or having GI issues. They're not falling or have a low heart rate. So they're not having any side effects from it. And you think it benefited them at some point, it seems reasonable to keep it on because maybe it's causing some kind of cognitive stability. That's kind of our practice, and the neurologists that I work with, that's kind of how they do it. Oh my goodness, my light keeps going off. But if people are having side effects or a lot of behavioral agitation, one of the things I will play with is maybe going down on the Alzheimer's meds. I'll kind of try both things. I'll go up on them if they're not on them. I'll go down on them if they're on them. So just tweak things and see if their behavior can get a little better. But what do you do with stable meds if people are doing okay? Usually I don't do anything. I leave them on, but we have that conversation. But that's kind of why I said in that slide, like, this is hard. And I think whatever you decide is okay. I hope that's not too political of an answer, but that's really kind of honestly, we don't know. So we kind of have to go based on our gut and what this science tells us. And please ask any follow-up questions if my answer didn't answer.
So this gentleman says, I'm moving my mother into an adult family home on Friday. I'm concerned about her anxiety and fear during the transition into a new place and routine. Is there a medication that might help for the transition? And I guess I would say, what do you typically use so that you're not giving medical advice?
Yeah, so I can't give medical advice. So I can't say like, oh, you should prescribe this. I would just go back to, let me see if I can. So for the transition, where's my behavior? I don't know where my behavior slide went. I probably, sorry, I'm probably making everyone. I do not routinely prescribe a med just in case, because they have too many risks. So it's a very rare scenario where I would put something on just in case. If someone's stable and has pretty normal behavior and they're moving, I don't do anything. I give families information and the facility, our phone number, and say, give me a call, or if there's any changes. But I don't prophylactically prescribe medications. Because sometimes the move goes great, and then you put someone on a medication that could increase their fall risk for no reason. You don't know until you try it.
So the follow-up on that question was that she's on low-dose Prozac and gabapentin.
I see. Yeah, I'm so sorry that I can't give individual medical advice. That would be, there's a lot that goes into that kind of thing. There are times and places for short courses of these medications. But, it's so individualized. It's even hard to even whip out a couple of names of medications because it so depends on the situation. What I would say is if someone has pure anxiety, and their liver's okay and they are not a huge fall risk, I think an anti-anxiety would be okay, like lorazepam, if they're not particularly old or frail. On the other hand, if there's a lot of psychosis, then you might reach for an antipsychotic. So they're having a lot of hallucinations. That's when I would reach for more of an antipsychotic like Seroquel or like risperidone, depending on. So it really kind of depends on the types of symptoms.
Do you think that there would be value in reaching out to her physician who knows her and providing them the scenario and saying, this is what my concern is, what would you recommend?
Sorry, can you ask the question again?
Do you think that there would be value in contacting her primary care to let them know what that scenario is, that she's moving to an adult family home and you're concerned, and what do they recommend?
Oh, yeah. Yeah. So I think that's a fair thing to do, to let so you're asking, should you let the primary care doctor know? And then if you do have to call in something emergently, they're kind of on, you know, they've thought through it a little bit. Yeah, I think that's a reasonable thing. Absolutely. And so what I would say is, like, big picture stuff is, if it's pure anxiety and they're not frail and not as high risk of falls, and anti-anxiety like lorazepam, which is on this slide here. So your Valium type meds, lorazepam is a safer one for older adults as needed. You know, or this is the medicine I prescribe if someone's super anxious and they can't get an MRI, but you really want one, you know, or they need to get on an airplane to go to a funeral. I will prescribe lorazepam for very limited situations like that. So pure anxiety, lorazepam. If they're having a lot of psychosis, like hallucinations, delusions, they think they're somewhere else. That's where you do like more of an antipsychotic, like Seroquel or risperidone are the two I would tend to use depending on certain scenarios. So those are kind of I know I said I wasn't gonna name endorse, but those are the kind of two scenarios I think through if I'm going to use a short-term medication. And then of course low doses, trial off. My practice is also, if I start a medication, or I try to do only one medication at a time, or one change at a time, with the exception that if I think a medication is harming someone, I might stop it and then start another thing. But I really try to only do one thing at a time, because if I do 3 things at a time, I won't know what helped, you know. So that's kind of my big approach. And then there's a whole bunch of other things that you do. So that's like for an acute setting. If someone's having like mild agitation and they're sort of stable with it, you know, first I try the Alzheimer's meds. If those aren't working, then I try an antidepressant. We also try to make sure they're not in pain and all that kind of stuff. So hopefully that's some advice. I don't know.
So this lady says that her sister, age 79, has mild to moderate cognitive impairment from vascular dementia. Mm-hmm. It has seemingly exacerbated her paranoia. If something is missing, someone stole it. Is there a particular class of medications that is more helpful than another?
Yeah, that's a good question. Vascular dementia is a tough one. What I would say is the Alzheimer's medications can be helpful in vascular dementia, because a lot of times vascular dementia patients have Alzheimer's pathology too. So if they haven't tried any Alzheimer's meds, that's probably where I would start, if they don't have any of those contraindications. So I would start there. Otherwise, the paranoia stuff is really hard to treat, because it's actually, the brain is responding to kind of normally. Imagine you have memory loss and you can't remember where you put something because it's not there. You're remembering a different day or a different life. Your normal response in your brain is, well, somebody must have taken it. And so that's kind of hard to treat. The treatment is really gentle reassurance and making sure their environment is safe and doing everything we can to deal with the paranoia in a gentle way possible. That's not always easy to do, and it's hard for the family members to be accused of the paranoia, but I start by explaining to the family that the brain is just trying to understand what's happening. And so the paranoia or the accusing of stealing and all that is kind of a normal response to an abnormal brain, and hard to treat with medication. So I start there. And then I do try the Alzheimer's meds, and then the gentle just redirection, like, you stole my keys. Oh, what are your keys for? Tell me about your car. I mean, that doesn't always work, but those are my tricks, I guess.
You mentioned vitamin D and falls. How does vitamin D impact falling?
Oh, just to be clear, B as in boy or D as in dog?
Oh, well, B or D as in dog.
Yeah, D as in dog. Yeah. So there are some studies that suggest that, especially around here where we all get low vitamin D as in dog, that we should all be on maybe about 800 to 1,000 units of vitamin D as in dog. So other studies say, oh, maybe not, but I don't think it hurts us to be on a kind of low dose vitamin D. Some people would say you should check it. Other people say the test is expensive and just take it. So it's kind of a contentious topic if you talk to the experts. But reviewing for my boards this last month, I think making sure that people are on appropriate vitamin D, if you're not, if your diet doesn't include like a lot of milk and stuff like that, you may get enough vitamin D from milk, or if you're outside a lot. But of course, the sun in Seattle goes away 6 months out of the year. So yeah, I'm an advocate for taking a multivitamin with vitamin D in it, or just taking vitamin D. And it strengthens our muscles and our bones. So that's probably why it prevents falls. Sorry, that was kind of a long answer. But yeah, I think vitamin D is one of the vitamins that might help us.
But since you mentioned vitamin B as in boy, can you speak to B12 and the deficiency in B12 that mimics dementia?
Yes, anybody with memory loss should have a B12 level checked. And then if it's low, it should be repleted. But you should definitely check a B12 level. And because that, if it's really low, it indicates you have trouble absorbing it. And so you may need to get it a different dose.
Okay, thank you.
Yeah, that's a slide I should have made it. Thank you.
This lady says, my mother-in-law has dementia and the doctor wants to do an MRI to see if she's having small strokes. She's 93. At what point do we say stop the expensive testing and put her tests? Would she benefit from the information gained and meds provided for possible TIAs?
Yeah, that's a good question. That's a really good question. And does the age matter? I mean, I think it's a really good question. What I would say is, when I see a patient in my clinic, and I want to give advice about prognosis and information, it is so much easier to give that information if we have a more clear diagnosis. And it is easier to give a more clear diagnosis when we have the imaging or the testing. If someone is in their older ages, 93 is certainly in the older ages for sure. Can you do those diagnoses and things without imaging? I think you could, and you could do a trial of medication without it. I certainly, if I saw a patient in my clinic and they had all the signs and symptoms of like Alzheimer's and things like that, and they couldn't get an MRI, let's say they had a pacemaker, they just couldn't or wouldn't get imaging studies. I think you can still make a diagnosis without imaging and proceed and do things. So I don't think it's absolutely necessary. But yeah, what does it add? What it adds just in general is the MRI rules out surprises, kind of clinches the diagnosis, and may help with prognosis. But if you're kind of sure about the diagnosis already, or if you're kind of leaning between vascular or Alzheimer's, you're right, it may not be absolutely necessary to get imaging on every person. That's a good one. And I don't think there's necessarily like an age cutoff where we're like MRIs are only helpful up to this age and not this age. And Medicare will cover it. So there's that. But you're right. It's kind of like, when we order tests in medical practices, like, will this test change management? And, at the end of the day, it may not dramatically change management unless it found something crazy. Yeah, I don't know. Probably not.
Well, plus the benefit versus burden. If that person is not able to understand why they have to go into this cigar tube and
right.
And
yeah, if they can't tolerate the procedure, I mean, I would never want to sedate someone for that, Like if someone really can't tolerate an MRI, there's a very rare case where we would really sedate someone to get an MRI, like a really young person, or you really need to know, is this psych or is this a rapidly progressive prion disease or some rare zebra, if you're debating between Alzheimer's and vascular, they're kind of treated the same way anyway, in some ways. I mean, I would say if you're much younger than that, they have very different prognoses. So it would be helpful to know. But in a 93-year-old, it's like, I don't know if the prognoses are going to be that much different.
Do any of the medications that you have discussed interact with diuretics?
That's a good question. I don't believe that the FDA approved medications for Alzheimer's, so Memantine, Donepezil, and friends interact with much medication, with the exception of, if someone is on a really potent diuretic and they're getting dehydrated or something, but it shouldn't. I kind of gave medical advice there, but that one I felt okay with.
Can you speak to the use of Haldol? This is one of our professional colleagues, and she says she sees it in use quite regularly.
Yeah, so I think Haldol is kind of falling out of favor in like the dementia world because it's a first generation antipsychotic, and if anybody has any hint of a Lewy body process, Haldol is just really not good for that patient. And there are a lot of people walking around with mixed dementia. So they have a little of this and a little of that, a little vascular, a little Alzheimer's, a little stroke, this and that. And Haldol is the worst thing you can give someone with Lewy body. So I think if you're at all worried about Lewy body dementia, even giving someone risperidone or something's not great, but so that's the second generation antipsychotics, but Haldol, can really precipitate tardive dyskinesia and some of those things. So as a geriatrician, like for me, Haldol, I don't like it because there's better alternatives and because of the Lewy body thingy. But if you're dealing with like young old patients, like you're dealing with, young onset Alzheimer's, like you're 50-year-olds with Alzheimer's, or frontotemporal dementia patients in their 50s or 60s, and they're in a psych unit or something, and they're otherwise healthy, Haldol may be okay if they're having behavioral agitation. But I don't use Haldol very often.
That was actually one of the questions. Any advice on medication related to frontotemporal dementias?
Yeah, that's a good question. A lot of these so the FDA approved medications for Alzheimer's have been shown not to help frontotemporal. I think the medications that have been shown to help frontotemporal are the what's called SSRIs, so the antidepressants like citalopram, those kind of medications. There are medications in clinical trials right now that may help the tau. So stay tuned for that. Of course, clinical trials I know take a long time, and they're never as quick as we want them. But there is an Alzheimer's Association equivalent for frontotemporal. It's like theaftd.org, I think is what it's called. If you go there, they have a lot of information about FTD that stays more current than I do. But yeah, the FTD is I think even harder to treat medically because it's a lot of behavior stuff that's really kind of human and ingrained, like frontal stuff, real kind of core stuff. And it's hard to treat with medication. It's a lot of behavior stuff.
So here is someone who says their spouse was tapered off Donepezil 5 milligrams, and they developed a sudden increase in confusion. They were off for a week and then back on 10 milligrams without any change in the confusion. Is
Oh,
this
wow.
possibly all disease progression?
Yeah, that's a good question. I mean, I can only speak to what the studies say, and this, when they taper people off of the Donepezil for crossover studies, they say they don't see any big side effects, or I don't know. Individually, I have case reports of people going off medicines and saying, yeah, I definitely need to be back on that medication. I haven't heard very many cases of people going off. I haven't heard of many cases such as that. So it's hard for me to know how to advise.
Okay. What do you think?
I guess here's what I would say is, if anybody has a really dramatic change in their cognition, and you could blame the medicine because it sounds like maybe, if someone has a dramatic change in their cognition, always consider delirium as a possibility. And it could just be a coincidence, until proven otherwise. Make sure they're not delirious, like getting sick, getting a UTI, getting dehydrated, so, making sure that we're not missing an infection or something. That's just kind of a general truth for dementia, because dementia shouldn't change rapidly.
So here's a fairly specific question. So what do you think about using lamotrigine 100 milligrams in the case of cerebral amyloid angiopathy, CAA, for emotional issues? And would the duration of use be an issue?
Yeah, I'm not familiar with literature on that. I think that's an off-label use of that medication.
All right, one more. Let me see where I'm at. You're not off the hook yet.
Yeah, it's okay. No, these are all really good questions. And I think, everyone's asking really good questions, and sometimes there aren't clear answers. And, we're trying the best we can to try different things. And I think one of the things to keep in mind too is probably the most important thing is that follow-up, those 2 or 3 follow-up visits, not just put on a medicine and walk away, but put on a medicine and keep follow-up visits and make sure, and go to up or down on the dose if needed. That follow-up visit is so key for so many things, both on the doctor side and on the patient side. It's so funny. I think, we're a big referring center, and we get a lot of really complicated cases. And I think there's this idea that, like, you go see the specialist and you get the things. Like, well, you go to the specialist and we ask a lot of questions, and then we still need to keep seeing you. The magic happens at visit 4. Like we finally figured out a plan, and so I tell my patients, the first time you go see a doctor, whether it's a cardiologist at Mayo Clinic or whether it's any doctor, like, that first visit is kind of hard. Like, you don't necessarily get a lot done. It's visit 2 or visit 3 that's really, you start clicking. Because you just think about it, when you're managing a chronic disease, there's just never going to be where you have the first visit and everything works out and the plan is perfect. And so what's really important is follow up. And, if the doctor isn't listening, definitely find a new doctor. But I think the caveat, though, is if you keep doctor shopping and don't give the doctor a little bit of a chance to do that follow up, you'll never get follow-up either. So it's a tough balance. I don't know how to exactly balance it, but hopefully people out there are finding doctors that are willing to listen, willing to look stuff up, willing to refer when needed, and doing the work, rolling up their sleeves and trying different things and listening. Really, that's the big key, is listening. So
this is a person who's been on Ambien for a long time. Is there
Yeah.
anything that we specifically should be aware of or concerned about?
Yeah, so I'm trying to remember if Ambien is one of those drugs on that anticholinergic list. You know, it's a good question. You know, as a general rule, we don't like people to be on sleeping pills for a long, long time, because if you look at the data, it does show that it doesn't necessarily help in average the amount of time that people actually sleep, and they do have side effects and cognitive risks and things like that. But anecdotally, I mean, I know people that just swear by it, they sleep better on it. And if you're not sleeping, that's bad as well. So that's a tough one. I think a good sleep specialist, if you haven't seen a sleep specialist, that might be a good place to start. Making sure there's no sleep issue that can't be fixed by other things. But it may be that it's on the anticholinergic list. And so, and I don't necessarily, want to scare people about every medicine they take. I mean, we all do things, our whole life is based on risks and burdens, right? I mean, I don't exercise every week at the exact amount that I'm supposed to. I had bacon in a sandwich today. FYI, you're not supposed to eat bacon. I like bacon sometimes, though, but I had some avocado to balance it out. So I think we have to recognize also that our life is a series of big things. And, if we have certain diseases like lung disease or rheumatoid arthritis or, different kinds of diseases, we're going to end up being on medications that have certain side effects in order to function. And that, that is okay. I think one thing that I do like to point out, that a lot of the medications that we are on for like sleep or for allergies or for bladder, there are other alternatives. So there are other alternatives to Ambien that might not be anticholinergic. So it may be that, if a sleep specialist might be able to get someone on like melatonin, and then they're only using Ambien once in a while, or, maybe cut back on the dose or something. So, if people are on some of these medications, or let's say you're on a bladder medication, because if you're not on that, you literally lose control of your bladder and you can't function at work. Like, you have to be on it. I don't want you to just stop it, but I think just knowing what the risks are, and making sure you've talked to your doctor about are there alternatives, and is there a time to trial off of it, so I hope I make that clear too, is that this is just kind of one approach and one piece of information. But
so you mentioned melatonin.
Yeah,
that is often recommended for people that have dementia.
Mm-hmm.
And, I've had people say it works like a charm, and I've had them say, what a worthless thing to use.
Yeah, I know. I kind of feel the same. I mean, there have been studies that have shown some benefit for around 6 milligrams seems to be kind of the average dose for older adults. You start at 2 and go up and up. But I agree. I have had a few patients swear by it, but I've had a lot of patients, especially if someone is so off on their sleep-wake cycle that they're up all night and sleeping during the day. Melatonin doesn't seem to help get people back to normal. But if they have just a little bit of sleep impairment, it seems like melatonin can help those folks. it's always worth trying since it's, the side effect profile is so low and it doesn't cause grogginess like some of the other meds do. I'm still here. My light, it doesn't know that I'm here. And it's so funny because I feel like I'm moving around, but it doesn't think I'm. Come on.
We know you're there.
Yeah.
So this person says, I feel that a medication review is warranted for my loved one. She is 89. Will her PCP be the right practitioner for this, or is it time to get hooked up with a geriatrician?
Oh yeah, that's a good question. I mean, the reality is there's not enough geriatricians for all older adults. So PCPs have to take this on. I think it's always worth starting with your PCP and maybe the pharmacist too. With those two specialists, you may get some information. I think geriatricians are really good for people that have a lot of geriatric syndromes. So people who are falling a lot, people who are losing a lot of weight, dementia or cognitive impairment, of course, especially if it's out of control. Frailty, people who are very frail. Those are things that geriatricians tend to have extra expertise in. So, I mean, of course, I'm never going to say, no, don't go see a geriatrician, but, but it may be that the primary care doctor, depending on how many meds there are and stuff, it may be that the primary care doctor can do a really great job with paring down the list and going through that with you. I think one of the things that's really frustrating is it's not that the primary care doctor doesn't have a lot of that knowledge. It's that they don't, I mean, you guys all probably know this, they don't have a lot of time. And the way that insurance companies reimburse and all this kind of stuff, it incentivizes doctors to see patients, like a ton of patients in a short amount of time. Whereas geriatricians have a slightly different payment model where they can bill a little bit differently and they can see a patient in a longer time. Like my new patient time slot is 80 minutes and my follow-up slot is 40 minutes, which sounds like a lot of time to a primary care doctor, but it's not enough time for me, but it's still a lot. But a primary care doctor, I think a new patient slot is like 40 minutes. Mm-hmm. I couldn't even imagine like trying to see a new patient with dementia in like 40 minutes. That's crazy. So, I mean, the whole system is a little crazy. So it may be helpful, and maybe somebody should do a study about this, is, whereas a family goes to a pharmacist and gets kind of a printout of their meds and a quick like once over, and the pharmacist stars the meds that might be inappropriate or to talk about. And then you go to your doctor and have a conversation about the starred meds, because you probably can't or don't have time for a discussion on every single med. But it may be that you don't need that. Like, oh, yep, these 3 meds are stable and fine. These 2 need to go. This one we have to have a talk about. Probably it's complicated, but it probably isn't complicated for each person, So I don't know, like that's it's such a good it's a good like systems issue, and depending on what kind of time your doctor or your primary care doctor, or sorry, I should say provider, because you might see a PA or a nurse practitioner.
Well, there is another question related to back to vitamin B.
Yeah.
One of them says, are there different kinds of B12? And sometimes it's given IV.
Yes. So my understanding is the new guidelines say that you should take the methyl B12, methylated B12 if you're, and I think a lot of the formulations are pretty much that. So it may not matter if it's oral. And then if you're getting, if your B12 levels are low, really, really low, you may get it IM or IV, intramuscular or intravenous in clinic, just so you absorb it. So as we get older, sometimes we stop producing this thing called intrinsic factor, or we don't produce enough of it. And so we don't absorb all of the B12 from our stomach lining. And we can bypass that by taking a really high dose orally, but it takes a while. It kind of depends on what your symptoms are, whether you should take the oral high dose B12 or whether you should just not pass go, don't collect $200, just get the IV or the in clinic.
So this lady says, my husband has been on the vitamin B for 5 years. Is there a timeline?
In terms of IV or
it doesn't say whether it's IV, just that he's been on the B12 and he has dementia. And does he need to continue it?
Yeah, I guess that kind of falls into, I would need to know more information. So I have to defer that to their primary care doc to get more information.
Well,
yes, but vitamin B, if you're not absorbing B12, you probably need to be on some form of it for the rest of your life. And so that is possible that he needs to be on something forever, but he might be able to be converted to an oral dose if he's not.
Oh, she says B12 pill, 1,000 milligrams.
Yeah. It doesn't hurt to be, you can't overdose on that, like that dose. Because what's happening is, so your stomach lining produces intrinsic factor, and then that grabs onto B12, and then you absorb it later on. If you don't produce intrinsic factor, you'll absorb about 1% of that 1,000, and that's about what you need. So hooray. So you're just kind of smushing enough in there to get enough. That's a scientific term, smushing in there. But yes, he probably needs that oral B12 for life. And it won't hurt him. It's cheap and easy. That's one easy thing we can do to help keep the other neurons happy.
And why is it used in dementia?
Well, it's not used in dementia. It's just used in anyone that has a low B12 that isn't absorbing it. And the reason it was checked was because he had memory loss. So probably he has dementia and low B12. So the B12 isn't going to cure the dementia, but it may have made, and I'm getting into medical advice again without knowing his case. But a lot of times we find both. So if anyone comes in, so there are rare cases where someone comes in with cognitive impairment and a low B12, and the low B12 is literally the only cause of the cognitive impairment. And you treat the low B12 and they're like better. That's pretty rare. That's usually like they've only been sick for a couple months. They also have nerve symptoms. That's pretty rare. Most of the time it's they have Alzheimer's, and you also incidentally discover a low B12. And so you get the B12 up to make things not less worse, right? But they still have Alzheimer's. That's what's usually happening there.
So the very last question, and there's lots of thank yous here.
Okay, good. Hopefully this is helpful.
No, it's been outstanding. So the very last question, and I think this is an important one to end on. My mother is 88. She's physically frail and slow moving, but otherwise healthy. Her dementia is a solid 5+ on the scale, the 7 scale. She's not on any dementia or Alzheimer's meds. I feel like there's nothing that's going to improve her condition at this point. Is it cruel of me to let this just run its course without medication?
Oh, well, let me just say, I mean, thank you so much for telling me about your mom. And, without knowing you or anything like, I mean, just the fact that you're here learning about this, I mean, it's not cruel at all. I mean, I'm just going to go back to this slide here. This is these meds are not a cure. They're symptom stabilizers that do help some people, but they come with side effects. And, whether they would help her right now or not, I mean, we don't know until we try. But when someone is in the later stages of dementia, they do help less and less. Okay. You know, and because the goal of the medication is to help, well, it's there's a couple goals. The goals are to help the patient have more memory so they can do the things they want to do, go bowling or do whatever, garden or ask less questions. And they sometimes also help the caregiver too. But if your mom is, you know, being taken care of, you know, doing, you know, basically safe and not having a lot of behavioral agitation and things like that, I mean, there wouldn't necessarily be a reason to poke around and start her on a medicine now. So no, it's never a cruel thing. You know, I think there's very few things in medicine that are like kind of, I don't know, like a no-brainer. Sorry to use the word brain. I think like
Perfect for
certain things,
dementia.
well, like some of the things, like we're kind of fighting around this in our country right now with vaccines, and vaccines are tricky because they affect other people, right? Like if I'm not vaccinated and I go out, I could cough on someone else and hurt them, and they, you know, so that's kind of tricky. And I'm, you know, so maybe vaccines is a whole bag of worms, but I think vaccines we really should be, you know, doing, or, you know, things that are like life-saving that, you know, could give someone, you know, letting a kid die of appendicitis. I think, why would you do that? Like, but medications for chronic diseases, you know, they have their benefits and they have their burdens, and there's no one right way to treat dementia in that way. So absolutely, you're not being cruel at all for not rushing out and saying, I need to try this medicine. But now you have some information, and if there's a change in condition or really behavior agitation or something, now you've heard a talk about it. Now you have some knowledge in your back pocket you could pull out and reach for. And, you know, if you did try something down the road and it didn't work, then you could stop it. That's the beauty of these medications that I really like, is the medications for dementia are pretty safe, they're well tolerated, and you can always stop them. And you don't have to start them. So you have lots of options.
Well, thank you so much.
It's
Dr.
helpful.
Hanson.
And, you know, I thank you.
Wonderful.
Thank you all for sharing your stories too. I mean, I've heard a lot of stories very similar to all yours, and I just thank you all for being out there on the front lines. And you know about our clinic now. We're in up in Harborview in Seattle. We do see people telemed, so your doctor can refer people our way, or go to our website, and which I think is somewhere in this talk. And thank you so much.
Thank you. Now, did you say that your slides would be available, that I could send them out if that was something that people wanted? Is that all right?
Yeah, I can send you the slides.
Okay. Okay.
Absolutely.
If nothing else, it might be something for them to take to their doctor and say, well, I heard this, tell me about it.
Yeah, and it's easier to click on the links too, rather than try to hand type it in.
Sure. All right. Thank you, Dr. Hanson.
Thank you,
Thank
everyone.
you all for being here.
Thank you. Have a nice rest of your week, everyone.
You too. Bye-bye.